I'm Dr. Kevin Cavanaugh, Board Chairman of HealthWatch USA, and I'd like to discuss with you today the COVID-19 pandemic, along with the characteristics of the virus and the illness it causes. In this presentation, it needs to be remembered that much of this information comes from reporters' interviews with researchers and scientists, along with pre-publications of their research. As more and more research is published in peer-reviewed journals and studies are corroborated, expect some of this information and guidance to change. Coronavirus disease 2019 is caused by the SARS-CoV-2 virus. The SARS-CoV-2 virus is composed of a strand of RNA surrounded by a lipoprotein capsule. The virus cannot reproduce by itself. To do so, it must enter a cell. The virus's capsule is surrounded by spike proteins, which are key to cellular entry. RNA viruses have a high mutation rate. Those mutations involving the spike proteins are of utmost importance. The body produces two types of antibodies to fight this virus. The first are binding antibodies, which bind to non-critical portions of the virus, such as the capsule, and are not effective in deactivating the virus. The second are neutralizing antibodies, which bind to the spike proteins and inhibit the virus from entering a cell. There are 4 other coronaviruses which cause about 20% of colds. However, the COVID-19 virus is different. It is related to the MERS and SARS coronavirus, which are very serious and rare viruses. Unlike the cold coronavirus, the SARS-CoV-2 attaches to the ACE2 receptor, which is found throughout the body, and a runny nose, which is often caused by common cold coronaviruses, is a rare symptom with COVID-19. Immunity to the common coronavirus is relatively short-lived, with one study finding it lasting approximately 1 year, and another study finding a substantial reduction in antibodies at 6 months. It is hoped that the immunity to the SARS-CoV-2 virus will be longer lasting. However, recent studies cast doubt on this occurring. Needless to say, these observations have caused concern for the development of herd immunity. A recent study in Nature found that 39 days post-infection, 33% of patients had a low neutralizing antibody level. Another study out of China found that 2 to 3 months after symptom onset, 40% of asymptomatic individuals became seronegative, and 12.9% of the symptomatic group also became seronegative. Finally, the virus has already mutated to a second strain, which some feel is more infectious than the original. This demonstrates the propensity of an RNA virus to mutate. The mutation affects the spike proteins used for viral attachment, but luckily it does not appear to affect vaccine development. Antibody levels in the community after being affected by COVID-19 have been measured and unfortunately have been found to be disappointingly low. In Sweden, SARS-CoV-2 antibodies were measured and were found to be present in only 7.3% of Stockholmers. In Spain, the seroprevalence of antibodies was between 4.6 to 5.0. In Los Angeles, the seroprevalence has been measured to be between 1 to 2.1%. And in New York City, a city which was ravaged by the coronavirus, antibody levels were found to be only in 6.9% of the population. A South Korean study reported that 111 individuals who initially tested positive for the coronavirus became seronegative and then later on redeveloped a positive test. It was felt that this was most likely due to reactivation of the virus. In a follow-up study of 285 similar cases, 44% of the patients redeveloped symptoms, but none of the patients were found to be infectious. R0 is a measurement of the infectivity of a pathogen, and R0 of 3 means that on average, one infected individual will spread it to 3 other people. It is estimated that the SARS-CoV-2 virus has an R0 of 5.7, placing it in the same category as smallpox, polio, and mumps. The seasonal flu has an R0 of 1.3, meaning that if 3 people are infected with the flu, they will in total spread it to approximately 4 other individuals. So it must be asked, Will we develop herd immunity? Well, with an R0 of 5.7, it would take over 80% of the population to become immune for this to happen. And even if it did happen, the observations of fading immunity in individuals and the low rates of immunity in communities make it unlikely that herd immunity will naturally take place. So our best strategy is either the use of masks, social distancing, and hand hygiene, or to develop an effective vaccine, or both. Many people are confused regarding the different types of coronavirus tests, and all of these tests have different false positive and false negative rates, along with different indications for usage. The most common test is a molecular test or a PCR test. This test is commonly used to diagnose a person who is actively having a COVID-19 type of an infection. This test has a low false positive rate. It is run in a laboratory, and it usually takes up to 48 hours to get back. Unfortunately, in some areas of the United States, this can take up to 2 weeks. There is also a rapid variation of the PCR test. 2 companies currently make this. They can take anywhere between 15 to 45 minutes to get back the results. Unfortunately, it tends to have a higher false negative rate, sometimes being measured at between 10 to 15%. Thus, these tests are primarily used for rapid screening of individuals when they go into a certain type of a venue. I would say that they are not completely accurate, but they are, however, much better than temperature checks. The second type of test is an antibody test. Antibody tests are used to diagnose whether or not you have had an infection. They are administered after a patient has resolved the infection and resolved symptoms, but neutralizing antibodies hopefully are still in the blood, which can be measured by this test. Unfortunately, these tests to date have been shown to have a fairly high false positive rate, and they sometimes react with other common types of coronaviruses. They are mostly used to determine and screen for prevalence of immunity in communities rather than for making treatment decisions on individual patients. It is hoped that in the future, antibody tests will become more accurate. The final type of test is an antigen test. This test measures viral proteins. It is similar to that of the strep or flu test. It is very quick, but currently we only have one test being available, and it is of questionable reliability. However, if this test becomes more reliable, or if different antigen tests enter the market, this type of test could become a game changer. And finally, there's the concept of pool testing. Pool testing involves the collection of samples from a number of different individuals, usually ranging between 3 to 50, depending upon the prevalence of the coronavirus infection in the community. All of these samples are pooled into one and tested at the same time. If this test is negative, then all of the samples are cleared. However, if positive, then each individual sample will need to be retested. I would like to now discuss the symptoms of COVID-19. Many people think that this is just the flu. Well, this is not just a respiratory virus. Fewer than 20% of those infected will show up at a hospital having a sore throat or runny nose. During the first few days of infection, you are much more likely to have a fever or dry cough, and particularly you may lose your sense of smell or taste. Symptoms of COVID-19 tend to have a very long incubation period. Symptoms usually appear 2 to 14 days after exposure. Death can occur 2 to 14 weeks after symptoms appear. Diagnosed cases also lag behind the onset of symptoms. Exceptions, of course, would be those patients who are found through case tracking and are identified as asymptomatic carriers. According to the CDC, common symptoms are fever, chills, cough, shortness of breath, fatigue, muscle or body aches, headaches, loss of taste or smell, sore throat. Rarely you can get a runny nose, nausea, vomiting, and diarrhea. A study published in CDC's Morbidity and Mortality Weekly. Symptoms for the novel coronavirus are given. the most prevalent being cough, fever, and shortness of breath. After that, myalgias, diarrhea, nausea and vomiting, and sore throat were commonly observed. It should be noted that in this article, loss of taste and smell was not noted. It took some time for science to identify that this symptom was commonly related to COVID-19. It should be noted that contrary to popular belief, taste is actually highly tied to the sense of smell. When one loses a sense of smell, they also to a large part have disturbances in their taste. In one paper which summarized a number of other studies, it was observed that olfactory or smell dysfunction occurred in almost 53% of COVID-19 patients, and problems or disorders of taste occurred in approximately 44% of patients. The BBC reviewed a study of patients who had difficulty with taste and smell and found that 90% of these individuals had resolution of their symptoms. However, in 10%, difficulty persisted. This would equate to approximately 4 to 5% of all COVID-19 patients. And a large portion of patients who are infected with the SARS-CoV-2 virus are asymptomatic or pre-symptomatic. In one study, it was estimated that 44% of infected patients could be traced back to a pre-symptomatic carrier. In another study, pre-symptomatic transmission was found in 48% of patients in Singapore and 62% of patients in Tianjin. Robert Redfield, the director of the CDC, has stated, a significant number of individuals that are infected actually remain asymptomatic. That may be as many as 25%. That's important because now you have individuals that may not have symptoms that can contribute to transmission, and we have learned that, in fact, they do contribute to transmission. A review study published in the Annals of Internal Medicine reviewed 16 other studies which reported rates of asymptomatic infections, and they concluded that the likelihood of approximately 40 to 45% of those infected with SARS-CoV-2 will remain asymptomatic, and that this suggests that the virus might have a greater potential than previously estimated to spread silently and deeply throughout the populace. Asymptomatic individuals can transmit the SARS-CoV-2 virus to others for an extended period of time, perhaps longer than 14 days. SARS-CoV-2 can actually cause severe outcomes in a number of patients. This is data from a CDC study which analyzed cases which were supplied from local public health laboratories. They found that on average, 20 to 31% of COVID-19 patients required hospitalization, 5 to 11.5% required ICU admission, and between 1.8 to 3.4% died. Adverse outcomes of hospitalizations, ICU admissions, and case fatality rates were very rare in the 0 to 19 age group, with no observed ICU admissions or case fatality rates. However, between 14 to 20% of the hospitalizations and 2 to 4% of ICU admissions were in the age group of 20 to 44 years. There are a number of comorbidities which are associated with severe outcomes in COVID-19 disease. These include hypertension, obesity, chronic metabolic diseases such as diabetes, chronic lung disease, heart disease, neurological disease, and renal disease. Of these, hypertension may actually be a secondary factor and not a primary comorbidity since it is associated with so many of the other disorders. Obesity is probably a primary comorbidity of utmost importance since it in itself may change the way the body responds to an infection. COVID-19 affects almost every organ of the body, and after a patient recovers, there are reports of prolonged symptom duration and disability, and that this is common in adults who are hospitalized with severe coronavirus disease. A recent paper from Italy surveyed patients 2 months post-hospital discharge. they found that 87% reported persistence of at least one symptom. Shortness of breath occurred in 43% of the patients, tiredness in 53% of the patients, and there was a worsening quality of life that was observed in 44% of the patients. Patients also commonly reported joint pain, chest pain, persistent cough, and anosmia. A study from the CDC surveyed patients who were from an outpatient setting with milder forms of COVID-19 illness. The survey was performed between 2 to 3 weeks after testing. 35% of patients at that time had not returned to their usual state of health. Patients commonly complained of fatigue, cough, dyspnea, chest pain, abdominal pain, and confusion. In another study from the Lung Foundation in the Netherlands, 1,622 patients who complained of persistent symptoms were interviewed. Of these, 91% of the patients were hospitalized. 88% reported intense fatigue, 74% shortness of breath, 45% chest pressure, 40% headaches, 35% muscle aches, 29% dizziness, and 90% stated they had problems with simple daily activities. The Atlantic reported on the phenomenon called long haulers, and one of their scientists stated that as the pandemic progresses, the number of people with medium to long-term disabilities will increase. Some science fiction and more than a few biotechs have led us to believe in a non-disabled future. But whether through environmental catastrophe or new viruses, we can expect more exacerbated and new disabilities. There have also been a number of studies which have reported a myriad of long-term symptoms in COVID-19 patients. A study reported in Brain analyzed 43 SARS-CoV-2 patients which complained of neurological symptoms. They found 5 major categories. 10 patients were categorized as having an encephalopathy, 12 an inflammatory CNS syndrome, 8 ischemic strokes associated with hypercoagulability. 4 of these patients had pulmonary thromboembolisms. Another 8 patients had peripheral neurological disorders, such as Guillain-Barré syndrome. 5 patients had miscellaneous CNS disorders. The authors felt that longitudinal follow-up studies would be necessary to ascertain the long-term neurological and psychological consequences of the COVID-19 pandemic. Hematological findings are also common. One study stated that COVID-19 infected patients, whether hospitalized or ambulatory, are at high risk for venous thromboembolism, and early and prolonged pharmacological thromboprophylaxis with low molecular weight heparin is highly recommended. Pulmonary embolism was noted in the neurological report, which was published in Brain. It was also noted by another author to occur in 20% of ICU patients. And another report stated that 31% of ICU patients had thrombotic complications from COVID-19. Thus, hypercoagulability in COVID-19 patients is a significant problem. Heart symptoms are also being commonly reported. In a study out of China reported in JAMA Network, out of 416 consecutive patients with COVID-19, cardiac injury occurred in 19.7% of patients during hospitalization, and it was one of the most important independent risk factors for hospital mortality. 51% of those with heart damage died, compared to 4.5% without damage. In an autopsy study out of Germany, in 39 patients who died of the virus was found in 24 of these patients, with high cardiac viral loads found in 16 patients. Another research paper studied a cohort of 100 patients who recently recovered from COVID-19. These patients were identified from a COVID-19 test center. Cardiac magnetic resonance imaging revealed cardiac involvement in 78 patients, and ongoing myocardial inflammation was identified in 60 patients. All patients were a minimum of 2 weeks from original diagnosis. Kidney disease also is a common problem in COVID-19 patients. In one study, out of 101 patients admitted to Wuhan Hospital, at the time of admission, 50% of the patients had proteinuria and 27% had hematuria. 5% developed acute kidney injury, and this was associated with an increased risk of mortality. In another study, over a third of 5,449 patients admitted to Norwell Health in New York City developed acute kidney injury, and 14% of the patients who developed injury required dialysis. 90% of patients who required ventilatory support also developed acute kidney failure. Finally, persistent lung problems are very common. The sicker the patient is, the more likely they will develop pulmonary fibrosis. Most patients who require ventilatory support or ECMO with COVID-19 may develop pulmonary fibrosis. Many patients requiring oxygen administration are expected to have permanent lung damage, but the extent of which requires further research. There is even concern that some degree of permanent lung damage can occur in about half of asymptomatic patients. Thus, we need to start to view COVID-19 as a long-term disease in many individuals and treat the virus with the respect it deserves. We should stop referring to patients as recovered, when in fact all too many are just survived. You recover when you return to normal health and activities.